The basic outcome of a cancer patient is not related to the clinical tumor mass, but it is rather related through very tiny amounts of cancer cells. They are called micrometastases that vagabond or are disseminated in the bloodstream. The entire wealth of literature worldwide tells the same story. Success of therapy, failure of therapy can be measured through genetic or genome analysis in disseminated cancer cells in the blood or the bone marrow. We follow by genes the drug pathways within a cell and detect by that approach whether a drug would work or has worked or not, or whether you have resistance factors. So we also detect resistance factors in these cancer cells.
So when Dr. Scheller sends his patient's blood to your laboratory, you tell him exactly which chemotherapeutic agent to use for that particular patient's cancer.
The blind therapies, as it is done worldwide, have, well, the FDA says in 80% that sort of drug is useless. We know from our enormous number of patients that from these 80%, another 60% are not only useless, but facilitate metastasis formation because the cells have gained resistance factors.
So the drug can cause cancer?
Oh yeah. Oh yeah, that has been known since decades. And we were the ones who identified these resistance factors in those cells that should be treated. And on the grounds of Kaplan-Meier diagrams, we found that many resistance factors can produce metastasis. So if you put all that together, the prediction value, that means will a drug work or not, at the moment is 81%, measured over all tumor entities that we have studied. That is a very high predictive value. It's much higher than you would obtain by doing the same sort of study within a clinical tumor. And the reason is disseminated cancer cells have a different makeup of genes than the clinical tumor would have.
So the tumor and the living cells that slough off the tumor need different treatments.
So we study in these cells what kind of DNA operations are there, and we study which kind of genes transcribe DNA into RNA. And we do that quantitatively in cancer cells versus benign cells. That's the whole story. And the outcome for patients is enormous.
And conventional medicine does not take this into account.
One of the most amazing stories Dr. Scheller and myself have in common was a successful treatment of a colorectal cancer with Herceptin. That was a patient who had metastasis from that primary tumor, and we did the routine assay which drug would work. And we found Herceptin would work. So the patient was treated with Herceptin and all metastases had gone after some while. So what is behind that story? A drug does not ask the cancer cells, where are you stemming from? Are you a breast tumor cancer cell or colorectal or whatever? A drug would work if the cell, the target cell, the cancer cell, is susceptible. So that means pharmacogenomics in target cells. So Dr. Scheller and other colleagues treat their patients after pharmacogenomic results, regardless of what the tumor is. And the outcome, what we know from many patients, and what we have also analyzed through mathematicians, by mathematicians, is people whose disseminated cancer cells are either inactivated or even better removed from the bloodstream live longer, by whatever means you achieve that.
Professor, why don't more doctors use your system?
Why clinicians are not using that system? In Germany, I can give you a very concrete answer, that is money. A physician makes more money, the lousier the situation of the patient is.
Wow.
You know, he makes more money from a patient who is metastasized than before that.
Are you saying they don't really want to cure cancer?
I have seen many people belonging to that establishment, when they develop cancer, they come to my office and say, now you have to look into my disseminated cancer cells. Let the other patient be behind me. I have witnessed stories, if I tell them, they would be unbelievable. From politicians, from well-known journalists, all that sort of stuff.